Okay, Renee.
All right. Well, good morning, everyone, and welcome to the Healthcare Summit. My name is Renee Bird-Lewis. I'm the president and CEO of the Gwinnett Coalition, Gwinnett County's lead community development organization. And our goal is to bring subject matter experts and organizations together in a structured way to achieve social change. And our vision is to ensure that all residents have the opportunity to thrive. Today, we are hosting our 6th Healthcare Summit in collaboration with the Gwinnett Newton Rockdale Health Department. And today's program will be offered in both English and Spanish via live interpretation. And this is our first time of trying to manage this on our own. So thank you for bearing with us as we work out the kinks. Even though we practice, sometimes things don't always go as you planned. And I'd like to take a moment to introduce Lizwina, I'm sorry if I didn't say your name correctly, Johnson, and Claudia Mendez Parker, who will serve as our interpreters today. They've come to us from Westbridge Solutions. And at this time, I need for everyone to sort of tune in for a minute and select the language of your preference for listening. At the bottom of your Zoom screen, you should see a globe, like the world, the globe. Click on that and simply select English or Spanish. And also, so that we can have the correct view of panelists as we continue the program today, please choose the speaker view, and you'll see a selector at the top of your screen towards the right, top right, for view. And if you select speaker view, then you'll be able to see probably me right now. And then in a moment when Dr. Mrna speaks, she will also be front and center on your screen. And even though we're using a virtual platform of Zoom, we want to engage you in the conversation and the information that is being presented. So if at any point you have a question or a comment, please enter that into the chat. Alana Solka from the Health Department will work to answer your questions along the way. And we might even save some of your questions for the panelists during the Q&A section. So now I'd like to roll right into one of our favorite people in the universe, actually, and that's Dr. Audrey Mrna. She graduated, even though many of you know her, it's always good to just know where she comes from. The University of California, San Diego, with a degree in cell biology and biochemistry. She graduated after that from the University of Cincinnati College of Medicine in '91 and completed an OBGYN residency at USC in Los Angeles. She's been in private practice as an OBGYN for 20 years. She served as a consultant to the Public Health Department and became its medical director in 2018. And now she is the, I think that was through 2018. And now she is the CEO of the District Health Center. So with that, the award-winning and the famous and the incredibly hardworking Dr. Audrey Mrna.
Oh my goodness. Thank you, Renee. It's so wonderful to see all of you this morning, and welcome to this summit. And I really hope and pray that everyone gets more information than they were even looking for, to say the least. I'm going to share my screen with you all. I have a lot to share with you this morning. So this is a picture of where we stand today. These are cumulative numbers. So worldwide, we're over 217 million cases. We're over 4.5 million deaths worldwide. The United States, as of this morning, is over 39,000 or 1,200,000 cases and over 640,000 deaths. Georgia, these are numbers as of last night, over 1.4 million cases. These are PCR and antigen confirmed cases. Deaths are over 19,000, and Gwinnett County is over 115,000 cases with 1,174 deaths. Now, these, like I said, are cumulative. So really, to get a better look at what level of transmission currently is in our communities, we look at case rates, 14-day case rates, and we look at 14-day published PCR percent positivity of our tests. So for Georgia, and I put a link in here, or not a link, but just a reference of July 4th, so you can see really what's happened with the presence of Delta variant. But 14-day published case rate as of this Monday, it changes on Monday, is 1,117 cases per 100,000. July 4th was 55. So you can see we've really had an escalated number of cases. The PCR percent positivity for Georgia is now at 17.4%. July 4th, it was 1.8. And I also included the case rate for our school children, age 5 to 17, because this is the highest age or case rates for this particular age, 5 to 17. You can see it's over 1,000 now per 100,000 population. And on July 4th, it was 21. So same thing for Gwinnett County, 14-day published case rate is now over 500 cases. July 4th was 44. Our percent positivity is at 13%. July 4th was 1.3%. Case rates for school-age children, 415, and July 4th was 10. I just realized I need to probably slow down for the interpreter, so I would try to do that. Vaccination-wise, just to give you some data, while we're talking about data, as of yesterday, the United States is 52% fully vaccinated. So if you look at eligible population of the United States, because it's not fair to look at those who aren't even eligible yet, 61% of the United States, and these are 12 and older age group, which is eligible for the vaccine. Georgia's given over 9.7 million doses, and fully vaccinated, still less than 50%, 43% eligible is 50%. In Gwinnett County, over 940,000 doses have been given, 49% fully vaccinated as of last night, eligible 57%. Again, this just tells you more or less why we're seeing the rise in cases that we are, because, you know, all of us healthcare professionals were worried and knew that eventually a variant would overtake you know, our ability, you know, to handle the pandemic. And that's what we're seeing, is because we still have less than 50% of our population vaccinated. So this is a really good representation. This is of Georgia, but Gwinnett's looks very similar, as does the United States. And of course, these are the waves. Everybody talks about a fourth wave. And this is, you know, back in April 2020 when the pandemic started, then summer in Georgia. This is higher than the United States, because when our temperatures are extreme like they are in the South, then we tend to you know, move indoors, and COVID spreads more when we're indoors. This peak, of course, was with the elections and Thanksgiving, Christmas, New Year's. If you'll notice, you know, this is when vaccines came out, and we don't see a rise over Easter, spring break, Memorial Day. And that's because we were winning, you know, this race, vaccine versus variants. We were winning. The vaccines were doing well until Delta. And Delta became predominant and spread like wildfire. And you can see, you know, the result of that has been the high rate of cases since then. So Delta is a variant of COVID. Remember, Delta is nothing but COVID. It's just a variant, which we'll talk about in just a minute, but it's extremely contagious, more contagious than before. This more deadly, we're watching very closely. I was going to remove that, but I actually put it back in, primarily because the hospitals, CMOs are telling me, the chief medical officers of the hospitals are telling me that people, when they get admitted with COVID now, are different than they were a year ago, because people are getting admitted and they're really tanking. They're really not doing well very fast. If you recall, a year ago, people would stay in the hospital for days and days and days, and then maybe succumb to and pass away from COVID. However, now what we're seeing are people are really sick when they're getting to the hospital, and they are not doing well very rapidly. So that may be because of Delta. I wanted to explain what a mutation is. This is basically a piece of genetic material, and all it takes is just one little area like this bright green spot really to change the genetics of a COVID virus. We see mutations in all the time, like, you know, kittens, a black kitten versus this, here's a white penguin, you know, as opposed to the others. You can see the mutations in corn. This particular mutation changes the colors of all the bugs. Of course, you know, this is a variant of the zebra down here, and even flowers in nature change. So you can see mutations are really normal. So it's very normal for a virus like COVID to try to mutate and get around drugs that prevent it and vaccines that prevent it and the like. So again, this is a race of disease. And we were winning this. The vaccine was ahead, but now we're seeing that the Delta variant is really challenging our ability to control this pandemic. So we are seeing in the hospital, this is a Piedmont slide, but over 96% of our hospital patients, ICU patients, people on ventilators are unvaccinated population. This is really what we're seeing of the COVID patients that are being admitted in the ICU and on ventilators. 96% of those are unvaccinated. Okay, so I'm not sure why that changed, but okay, here we go. So we talk a lot about risk assessment, and the risk of problems from the vaccine versus the risk of getting COVID. And this was shared with me yesterday by the state office. And so I thought I would share this. Of a whole football field full of people, these are the 38,000 number of people who have traffic fatalities in the United States every year. And when you look at how many gun deaths we have, if you have half of the stadium filled, we see this many fatalities from guns every year. So if we look at the number of deaths in the United States, so far, 614,000 of these of people, there have been deaths so far. And if you look at the proportion of this that has occurred after, these were all the deaths from before the vaccine came available. And then these over here on the right side are the numbers of deaths that we've had since the vaccine came out. And what's most important is that this small number right here of deaths are from the vaccinated population. So again, it really kind of gives you a perspective. When you look at this number, that's a huge amount of people. And just a small portion of those deaths have been with the vaccinated people. So we hear a lot of time, the myths will be addressed later by Representative Mitchell, but nonetheless, these are really real numbers. So I wanted to show you, this is a busy slide, but basically, this is what we're seeing with the advent of Delta, which is really right here. You can see that our ability, the ability of our vaccines to fight off Delta has declined. And it actually looks like Moderna is doing a little bit better than Pfizer. Remember, Pfizer came out first, so that may be part of that reason too. But the goal of a vaccine is really to prevent severe disease, hospitalization, and death. And you can see that our vaccines are doing still less so, but better job than normal. And again, what we're really concerned about, and when we talk about boosters, it's important for everybody to realize that, we're seeing a change in our vaccinated population getting mild to moderate disease or infections with COVID. And so the fear is really that, we're going to start to see the protection wane of the vaccine against severe disease, hospitalization, and death as well. And we're worried that that protection is going to diminish in the months ahead, especially with those who are at most risk, like our elderly, and also those who were vaccinated early. And so that's why we're talking about a booster right now that may be needed to maximize protection and ensure that the vaccine durability is there. So currently we are giving third doses of the mRNA vaccine, not the Johnson & Johnson, but Pfizer and Moderna, to severely immunocompromised individuals. And again, it's not considered a booster because we think these people need 3 doses, which are 28 days apart. And this is the list of what that means, immunocompromised individuals. So those who are receiving active cancer treatment for tumors, organ transplants, stem cell transplants, primary immunodeficiency disorders, untreated HIV or advanced HIV, and active treatment with medicines that really suppress our immune systems. And when we talk about boosters, we are waiting on full approval for the FDA and CDC in order to give boosters. We've been told September 20 is the kind of the date to be prepared for. So we're grateful that we had a month's notice to try to hire as many people we can to expect the demand for boosters when we're there. But again, we can't give these boosters until we get that full approval. So we are waiting for them. I do know that some pharmacies are already giving out the boosters, but public health is not allowed to go off label. And so we have to wait until we get full authorization to be able to provide it. The only way out of this pandemic is vaccination. Having COVID in the past is not enough protection against the variants that come out. We see that every year as we need a new flu vaccine every year, and it's the same is true for COVID. And as you probably heard earlier or late in August, Pfizer did receive full approval for its COVID vaccine, which will be marketed as Comirnaty. That's going to be the new name of the Pfizer vaccine, but it's only approved for 16 and older. So the 12 to 15 age group is still under emergency use authorization. The third doses and the boosters, if they're approved, will be still under emergency use authorization. So I don't want to lose the opportunity to make sure everybody gets their flu shot this year. Last year's flu season was extremely low. Because everyone was wearing masks and social distancing and being careful, washing hands and staying home if you're sick. We need everybody to continue to do that this year. Our hospitals, as you saw earlier, are very overwhelmed, and our healthcare system is very stressed and taxed right now. And so we cannot allow a flu season to be to contribute to the overwhelming degree of patients that are in the hospitals. And so we urge everyone to get their flu shots. Remember, a flu shot will prevent you from severe disease and death from flu. But also remember, when you get the flu, if you're not vaccinated, your immune system is depressed. And then if you get COVID on top of that, just like last year, we're really concerned about you being able to handle COVID on top of that. So I am going to stop sharing. And at this time, let me introduce our next speaker, if that's good with you, Renee. Our next speaker is Valerie Cadet. She is an associate professor of microbiology and immunology at PCOM, Georgia in Swanee. We're grateful that she's here today. She serves as the Director of Health Equity Curricular Initiatives for PCOM and for their medicine programs there. She earned a doctorate degree in infectious disease from the University of Georgia College of Veterinary Medicine. And she's co-leading PCOM's Georgia's COVID-19 vaccine education project. So welcome, Dr. Cadet. We're grateful that you're here with us and look forward to what you have to tell us.
Thank you, Dr. Mrna, and good morning, everybody. Let me go ahead and share my screen. And I think I did it right. So thank you so much. Let's see. Okay, so I always like starting these conversations about COVID vaccine developments with reminding us where we were and putting it in context of where we're going. So it's really complicated. There's been so much progress in a really rapid time. And it happened because the medical and the scientific community worked together really hard, tirelessly, under very challenging conditions. And then, of course, the general public cooperated and supported efforts such as, participating in clinical trials and mitigation strategies like mask wearing and cooperating with the shutdowns and things like that. But, time-wise, you can see, some of the key dates of this pandemic. We are actually almost 2 years out from this. So it was just December 8th, 2019 that the first patient was recognized as having this mysterious illness. About a month afterwards, it was really an outbreak that had started. Over 50 patients were recognized as having this disease, but scientists had already isolated and identified this novel virus, SARS coronavirus 2. And then by early March, the World Health Organization declared it a global pandemic. And just 2 days later, the President of the United States declared a national emergency. So there was unprecedented cooperation between pharmaceutical companies, both small and large, academic institutions, general public, and governments worldwide in order to run clinical trials that enrolled huge numbers of people, all with a common goal of determining the best treatment for this new disease, as well as creating safe and effective vaccines. So it led to early approved treatments, as well as the first emergency use authorization for a vaccine in early December 2020. And of course, we know we subsequently ended up with 3 vaccines available for use here in the US currently. It's impressively fast, but the coordinated effort and data sharing, collaborations, and commitments to review data basically in real time is what's made this possible. The process isn't over, and we're still in a phase of ongoing research, and the knowledge is definitely evolving with the science. So just to remind everybody of where we're at, we keep hearing it, and if you haven't seen it for a while, you may not remember exactly how these vaccines work. So what we're looking at on the left is a representation of what we'll call the J&J vaccine, the Johnson & Johnson vaccine. And it's a viral vector DNA vaccine. So it means that it is using an inactivated alternate virus. In this case, it's a cold virus, an adenovirus, and it carries the genetic material into the cell itself. So what you see in red is representative of the DNA that would encode for the spike protein for the coronavirus. So it ends up getting into the cell, and our cell makes what's called a messenger RNA, mRNA, from the DNA, and then that mRNA gets turned into a protein. And so now we've got spike coronavirus proteins that can be picked up by our immune processing cells and stimulate that appropriate immune response. So we want to see the antibodies that we talk about, and what's talked about a little bit less are T cells, but we do want to stimulate a robust T cell response at the same time. On the right-hand side, what we're looking at is representation of the mRNA vaccines, so the Pfizer and Moderna vaccines. And in this case, this is directly mRNA, and when this mRNA is injected, it's taken up and it's able to be turned or translated, as it's called, directly into that spike coronavirus protein, and in addition, then have the same response where we can stimulate the antibodies and T cells that our bodies need to later fight the virus if we were to encounter it. So a couple key points on the mRNA vaccines is that they are encoded with a lipid particle. And the reason why is because mRNA is actually pretty flimsy. It's kind of puny and wimpy. And so we have enzymes and proteins in our bodies and cells that will degrade it very quickly. It also needs help to get inside of the cell. So that lipid coating helps it not degrade, so it has a chance to be made into the spike protein. It never gets into the nucleus where our DNA actually is. So these vaccines can't alter DNA in any way. It's just, they're not even interacting. After the protein's made, the cell actually breaks down that mRNA pretty rapidly and then disposes of the mRNA, excuse me, it's early, and in the typical way that our cells do this. So just some basics there. So these mRNA vaccines, they still seem new, even though we've been hearing about them for over a year. But in fact, therapeutically in both preclinical and clinical trials work, we've been utilizing mRNA since at least 1990 and in some cases before. So there's no currently licensed mRNA. Well, actually, hold on. I can say that that's not true. I'm used to saying that, but actually we have Pfizer, the Pfizer vaccine, which is the first. But prior to these COVID vaccines, we had no licensed mRNA vaccines in the United States, but we had so much previous data with various infectious diseases, including the earlier coronaviruses, SARS and MERS, as well as other non-infectious diseases like genetic disorders such as cystic fibrosis, for instance, and other cancer immunotherapies. So as a result of years of previous work, mRNA vaccines were able to be moved rapidly into the clinic for initial testing to be able to be then fast-tracked to that EUA status that we have heard about so much. So in order to compare and contrast EUA to really get the difference between the two, we'll say this. So the emergency use authorization is a status that the FDA has as a mechanism to authorize formerly unapproved products for temporary use. The key is that happens during a public health emergency. So It was declared a public health emergency, as we know, officially by the president. And so it then prompted vaccine manufacturers to choose to submit requests for EUAs to the FDA after they had done their trials. So EUAs were initially established after the 9/11 terrorist attacks, and that was to ensure that, you know, potentially life-saving medical products could actually be made available during an emergency prior to the, you know, lengthy approval process of the FDA. But in order to issue an EUA, it has to be proven that the vaccines are safe and effective at preventing serious or life-threatening conditions, and that the known and potential benefits outweigh the known and potential risks. So let's contrast that. In order to achieve the full approval, the vaccine has to go through all 3 phases of clinical trials, and they have to be complete with the data analyzed and presented to the FDA. In terms of the EUA, interim data analysis could be presented, although the numbers had to be very high before the FDA agreed to take a look at that. And so with that full approval, manufacturers additionally do have to present data on safety and efficacy, as well as proving that the benefits outweigh the risk. And in both scenarios, the FDA also needs to take a look at the overall manufacturing process. So in actuality, those processes are pretty similar. So the EUA still was rigorous in terms of the FDA's examining of the data. And then for full approval, they took it to the next level. So the 3 vaccines, the Pfizer is, the brand name is listed there, and it's indicated approved for 16 years of age and older, but as Dr. Mrna described, it's approved through the emergency use authorization from ages 12 and up. And the other 2 vaccines listed are from 18 years and older. And you can see that there's ongoing studies. Pfizer has trials in place right now for children down to ages 5. Moderna has studies in children as young as 6 months of age, and Johnson & Johnson has studies where they actually just released information showing that providing a second dose, a booster, is really effective after 8 months of vaccination. So we'll be seeing that. And then Moderna actually just recently applied for full authorization of its vaccine. So we will stay tuned for that. So the big question is, how do we know these vaccines are safe in terms of ongoing? Even if we know that the processes to get them out to the public were, you know, intensely scrutinized, and they absolutely were. Well, there's a lot of systems in place to ensure the continued monitoring and safety. First of all, approved vaccines have to be labeled with the proper risks and benefits, as well as how to use it correctly. Healthcare providers have to share this information. They have to be able to share this information with their patients. Prior to an approved vaccine being distributed to the public, the manufacturer also has to test every batch of the vaccine for safety, potency, and purity. And the FDA has to review this information before the lots can be released. FDA also routinely inspects the facilities, like I mentioned before. So they keep doing that on a routine basis in order to ensure a quality and safe product. Healthcare providers are also charged with utilizing the vaccine adverse event reporting system. And so with this system, with this process, they would submit a report to VAERS if there was a serious adverse event that they saw with their patient. And this process is co-managed by both the FDA and CDC. So a novel tool that was created during the pandemic was utilizing vSafe, or having vSafe after vaccination health checker, so that could be utilized by people who've been vaccinated. So this process uses text messaging and web surveys, and it allows people to quickly tell the CDC after vaccination if you have any side effects. And depending on what your answers are, someone from the CDC may call to check on you and get more information. And then finally, using both the Center for Medicare and Medicaid system, as well as the Sentinel BEST system, the FDA and the CDC actually utilize health records and insurance claims in order to identify any additional adverse events that perhaps were not reported to VAERS, as well as ensuring continued safety, particularly with the CMS system for our elderly population, 65 years and older. So there are a lot of ways to continue to monitor that is happening right now. So a couple words that have already been thrown out that typically get asked are what is efficacy versus safety? And so I wanted to throw that in there. Efficacy is when we're talking about the degree to which the vaccine is actually preventing disease or possibly transmission under those ideal conditions. So during the clinical trials, the results that the manufacturers noted. However, those are, again, ideal conditions. So effectiveness is referring to real world scenarios. So how well is it actually performing out in the public? So when we look at effectiveness overall, so initially at the first phase, these vaccines were created for, really not the Delta variant. Let's just put it that way. They were created for the initial circulating variants of this particular virus that caused COVID. And so we saw an effectiveness that was pretty strong at, on the left side of the slash, we're looking at the effectiveness at preventing a symptomatic illness. And then on the right side, we're looking at effectiveness at preventing that severe disease and hospitalization. And so across the board, we had very good effectiveness here. In populations 65 and older, that effectiveness was slightly reduced in Moderna and J&J, but it was still very, very effective at preventing hospitalizations and deaths. And so now taking into consideration the Delta virus, this particular variant, in the face of this variant, the vaccine does still protect. We're looking at, the percentages are going to range from various studies. So, it's as high as 88%, and we've seen as low as around 72%. Moderna is a twofold decrease, but still very, very effective in all cases at preventing that hospitalization and death. So I talked about numbers, we talk about trials. Let's take a look at how all of these phase 3 clinical trials actually enrolled, meaning how did they take care to ensure that we had a representation that was appropriate within the individuals in the trial. So Pfizer had over 46,000 individuals enrolled in 153 separate sites around the world. And you can see where they were in South America, parts of Europe, South Africa, as well as the United States. And when you look at the diversity, that was a commitment that these manufacturers made very early on, that they needed to diversify the participant pool to make sure they're really trying to represent the general population. And so you can see, if we just focus here in the United States, we're looking at 6% Asian inclusion, 10% Black, 13% Hispanic, and just over 1% for Native Americans, and about 50-50 for male and female representation. And then in terms of age, as low as 12 all the way through into the 70s. So very, very good representation. Moderna was quite similar in that they enrolled 30,000 individuals. And if you look, these individuals represented a variety of work sectors. They had pre-existing conditions, some of which would have made them at more severe risk for higher risk for more severe disease if they were to be infected with COVID. So that's a great study population to include. We were looking at just over 20% Hispanic, again, 10% Black, and 4% Asian, with over a quarter of the participants being over the age of 65. And then Johnson & Johnson enrolled over 44,000 people at sites around the world, and 67% of them were between the ages of 18 and 59, and 34% over the ages of 60, and a good number of them also had that pre-existing condition. So we're talking about individuals that basically represent the common individual. Many of us have some sort of condition that we worry about, would this make us more at risk? And then in terms of the demographics via race, as well as ethnicity, they were pretty varied as well. So, I mean, looking at these numbers, we know that there were a huge number of people in these phase 3 trials. We already seen that these vaccines were very efficacious. So we know that the vaccines we have against COVID are effective, even if a little less so for this Delta variant. But no vaccine is 100% effective. I think a lot of us believe that these vaccines offer this complete protection from infection and not just severe disease and death. But some fully vaccinated people will get sick. That's just what actually happens. Dr. Mrna described it with the influenza shot, and we've seen this with lots of other things. So another point when we want to look at, these vaccines and this virus, we think about, are these breakthrough cases? So why are we having them? In addition to the fact that the vaccines are not 100% effective at preventing illness, they were really assessed to prevent severe illness, hospitalization, and death. That is where they are so strong and they are doing their job. But we do have the variants, particularly over 99% of the circulating virus here is Delta. It's more transmissible, causing more severe disease, and it causes infected individuals to have even more virus within their systems. So it's able to be spread a lot easier. You saw the numbers a moment ago in terms of how many infected individuals are out and about walking around. And so there's literally just a lot more virus that we are encountering. So the likelihood of potentially becoming infected is now higher as a result of that. But it doesn't mean that the vaccines aren't working. It just means that everybody who receives it is not necessarily going to have an asymptomatic infection. But we know over 96% of the individuals that are hospitalized and die from COVID are unvaccinated, proving that these vaccines are effective. So I wanted to touch on a couple of things that were making the rounds in the media recently. So natural immunity. I've had a couple of people call me. I've had others, send emails, and some of my other colleagues have said the same thing. Why can't we just do natural immunity? Go out there, get vaccinated, or expose ourselves and let that just be, because there's been a couple of studies that shown that natural immunity will give you a better immune response than being vaccinated. And so using this first study that you see on top, this is a study out of Israel. It was a very robust study. You can see the numbers are pretty high in terms of who was actually enrolled, how many were enrolled. And their findings were just what I just mentioned. But some of the stuff that's not fully explained sometimes when you hear about this is that in addition to having a prior infection being more protective than the vaccine, 2 doses of the vaccine, the individuals that had a prior dose actually had better protection from reinfection with a booster dose of the mRNA vaccine. So what does that really mean? That means that they were also susceptible to reinfection. What it doesn't mean, however, is that being vaccinated alone is not effective. And I think that that's a mixed message sometimes that's getting out there. Being vaccinated is very, very effective. Another thing that we see, another study actually that just came out in the MMWR with the CDC, is looking at individuals out of Kentucky. It was a population in Kentucky who showed a reduced risk of reinfection after the COVID-19 vaccination in comparison to those who had a prior infection and didn't get vaccinated. So when you kind of delve and dig in a little bit further, ultimately, that's kind of saying the opposite. But I think you have to think back on what's circulating. If you were infected with the Delta strain, that would likely, as long as you're immune competent, give you a better immune response. But many of us have been infected with prior strains, not a variant, not Delta. And so as a result, the vaccine is giving a better response. So take home message, I would say, is I know lots of people are looking for alternatives to vaccination for a variety of reasons, but natural immunity versus vaccination is not the best way. In terms of the amount of morbidity and high rates of mortality for people who are unvaccinated versus those who are vaccinated, I'd say the side effects for getting a vaccine the risk of getting vaccinated I guess the risks are much more reduced, is the way to say it, in comparison to just going out there and, going the natural immunity route. So I'm going to skip over this because Dr. Rowan already described the fact that, we are waiting to hear that, final authorization on who's going to get a booster, or when I should say we would get a booster. So that's coming. And then, wanted to touch on monoclonal antibodies, because that's also been a lot in the media. And people are like, well, what is that? So monoclonal antibodies are actually laboratory made antibodies that can help fight this infection, but it's not for everybody. If you see over here, there's a group of individuals who are at high risk of disease progression, and they have to meet certain criteria. So this is not something that is just out there and you just, everybody just goes and gets it, but it is a key tool for people at high risk of disease progression in order to slow that down if given early in the infection. So definitely wanted to show you that. And then finally, ivermectin. So this is, the hot new word. And ivermectin is an antiparasitic, meaning it's a drug that fights parasites. It is widely used in livestock, and it's also used in animals, some small animals as well, to fight heartworm. And in both small and large animals, it's used as internal and external parasite to get rid of them for the animals. There are a couple of uses both for humans that have been approved through prescription only for ivermectin. But a lot of people are utilizing or wondering if they should utilize it, on their own. And the key that I want to point out here is that the ivermectin utilized for livestock and animals is typically going to be a different concentration, and it may have additional ingredients. And so this has not been approved as an EUA for COVID-19 and only approved for human use with a physician's order. So the final take home is vaccines really are key here, along with masking and, the typical mitigation strategies like social distancing. So thank you very much. And I'll go ahead and turn it back over to Renee, if I can do that.
Yep. All right. Thank you, Dr. Cadet. That was really interesting information, and I love all the slides and putting the pieces together. It's my pleasure now to introduce and welcome Representative Rebecca Mitchell. She represents Georgia House District 106. Originally from upstate New York, Representative Mitchell earned her undergraduate degree in biology from Harvard and her doctorate in epidemiology from Cornell University. In 2013, she moved to Georgia. Dr. Mitchell has a background in public health research and a passion for driving positive change in our public health policy. She served as a visiting assistant professor at Emory School of Nursing and Computer Science. And for years, she worked to identify patterns in complex health data sets, including understanding infectious disease dynamics and the impact of vaccines and other interventions. So you can see how the data and the research all come together, and why she'll be a great speaker for our next topic. Earlier this year, I understand Dr. Mitchell joined Dr. Mrna and Gwinnett County Commissioner Jasper Watkins, and they walked door to door throughout their district, promoting the vaccination, but also wanting to hear from residents about their concerns and why they might not receive the vaccine. So with that as a backdrop, we've invited Dr. Mitchell to join us for a segment on discerning fact from fiction. So I'll turn it over to Dr. Mitchell.
Great, thank you so much, and nice to meet you all. I am going to talk to you a little bit less about my scientific expertise and more about how we're interpreting what's real in this moment where we have a lot of changing science coming at us. And as well as my introduction as to what I am paid to do, I also want to let you know that I am not paid to protect and make decisions for 4 small people who are currently going to public school and are currently under the age of vaccination. So when I look at data and when I try to interpret things, it's from a personal lens as well, that I am really working to protect the unvaccinated people in my household. And I am super appreciative of Dr. Cadet's review of what information there is out there. And we are really unique in having this forum where you know that all the information coming at you is coming from people who are standing in a place of expertise and who are accessing all the facts that are available to offer you the ability to make decisions based on truth. I think this epidemic is a really unusual place and time for public health. Public health is a field that moves in a very considered fashion. They take a long time to review all the evidence that is there to make sure that when we make a policy, we have to change it as little as possible, because the main challenge with public health is actually getting a unified message out and getting a policy applied and accepted universally. So it's really a space where we'd like to take our time and make the very best decision possible, but that just isn't possible in the middle of a pandemic because all the information coming to us changes so fast. If you go to the site where you can look at all the published data from scientists, and you Google how many COVID papers there are one day, and you go Google how many COVID papers there are the next day, that number goes up every day. The amount of information coming at us that needs to be synthesized into one policy, oh, sorry, I'm speaking too fast, that needs to be synthesized into one policy is immense. And it's actually impossible to do that at the speed at which information comes in. So what we see in public health is that we're getting messaging out that is consistent for a short period of time, and then it switches to new messaging based on new information, but we don't see that very dramatic scientific pathway that happens between those two pieces of information. We just see that the guidance that came to us changed. And I think that at the level of a consumer, the information that we get, it's so hard to look at that and trust it because we don't see the entire pathway. And I think we see that as far as information on the virus, but we also see that as far as information on treatments and vaccines. So there is a gap between the science that is truly happening, the communication that is uniform and consistent, and those of us who are trying to interpret it on the receiving end. And I think when we look at how we're discerning information, it is so important to understand that there are two forces working against us seeing the whole picture. One is that we exist in communities. We exist in those communities locally, but more importantly, we exist in online communities. So if we start looking at information online, we are going to see a group of information that we agree with and that our friends agree with. And other people are going to see diametrically opposite information that may even use the same data, and all of their friends are going to see the same thing. So there was a recent study, and the URL is on the bottom if you want to look at it, from MIT that actually looked at this question about what information goes out about COVID specifically and what groups there are. And each color here represents a group of people who are getting different information that they're seeing. And you can see that one group of people is green and one group of people here is red. And they will take the same piece of information and they will see only the loudest voices in their own group. And because one of those voices may be extremely dominant, you will hear information from that voice over and over again. So how do you know which bubble you're in and whether you are in a bubble is a really important question we have to ask ourselves, especially if we're getting the majority of our information online, which most of us are. And again, coming back to the fact that no one is really able to absorb all the information coming at us. However, at the same time, no one of us is a universal expert. I am pretty good at looking at infectious disease dynamics because I've had 20 years in that field. So I can look at multiple papers there and kind of synthesize them together. If you ask me about air filtration, I know zero. So I can serve as an expert in one place and say something exceptionally inaccurate in another. So knowing which experts can speak about which spaces and when you need to actually hear another expert is another skill set that we don't necessarily have. I cannot evaluate necessarily someone else's expertise in a field that's very far from mine. But we can kind of use the standards that are in place for us as our guide. So the question of who is the person speaking to you? Does it matter who they are? It does. Can you tell if they're theoretically trustworthy? Well, it depends. If I see a tweet that has been forwarded by my friends on Facebook, which I see a lot of, I often go back and try to find the author and say, who is that author and where do they fit relative to other experts in the field, and look at the host of information that they are putting out to know where they fit in my scale of, do I think this person is putting out trustworthy information? And I think that's something we all can do to make sure when we are taking in information, we know where it comes from. And then to look at the information you're presented in your bubble and say, is this aligned with our other trusted sources? And who do we define as our trusted sources? And there are several different groups these could fall into. So in public health here, when I reference folks, I reference CDC and I reference GNR, so Gwinnett Newton Rockdale Health, because they're both working to actively put out information, and it is in my social media sphere. So I know if something conflicts with what's coming out from those trusted sources, that I need to ask why it conflicts. As well, medicine, the most trusted source for most people is actually their doctor. So if you have a relationship with your doctor where you can ask them questions to make sure that the information you're taking in is valid, that's super helpful. I mean, we also have the NIH, kind of the research, and Dr. Fauci there as a second source of information. And then also looking at, people get a lot of information from their trusted sources in their own real world social network. So if the person that you trust the most and is helping talk about vaccines is the leader of your church, are they connected with GNR Health? Are they able to get the information they need to make sure that information coming to you has the most scientific data it can have in it? And one other thing I wanted to touch on is, what should we actually do about misinformation? And it's really important to realize that when you hear the same information wrong over and over, you tend to question whether it's wrong. And that doesn't matter if you're highlighting the inaccuracies in it or if you're saying it might be true. So I thought of a great example this morning. What if I told you all today that within 5 years, all of the pine trees in Georgia are going to be purple? Now, everyone might think about that and say, and I could say, because there's a new fungus that's changing leaf color and there's pollution, so they're able to absorb light better. It kind of sounds like it might be a thing. It sounds really strange. One of you might do research on that and be, no, this person is absolutely wrong, and put that out on the media. It is wrong that pine trees are going to turn purple, because it is wrong that pine trees are going to turn purple. But you know what? Everyone in your social circle just saw that someone thinks pine trees are going to turn purple. And if anybody amplifies your debunking because they want other people to know pine trees aren't turning purple, what we've actually done is amplified that misinformation at the same time we're trying to counter it. So when we approach misinformation, it's really, we think that we're out, if we are not a public health authority, we're speaking out against this misinformation. We can actually be doing more damage by not addressing the real problem there. So one of the advice that I've heard is, instead of addressing misinformation in our own personal bubble, instead put out correct information. So I get a lot of questions about ivermectin as well, and people asking, why aren't we approving this? And rather than going out and debunking that, because I don't have that trusted platform like Dr. Cadet's platform or Dr. Mrna's platform, what I can do instead is put out information about what we do to approve drugs. So what I talk about is how do emergency use authorizations work, and why are our doctors using different products over another? So a great example of what I put out is, for that particular question, is asking questions about emergency use authorizations. So how they work for therapeutics and how they work for vaccine, and the fact that that is a different, those are two different things, where our bar for therapeutics was lower than for vaccine, because our therapeutics are going to treat people who are actively ill. If there is a compound that has no evidence of harm and some evidence that it's helpful in clinical trials, then it often gets an emergency use authorization. If that evidence is not borne out, that emergency use authorization status is removed. So if I then tell people that if we look at the science behind these emergency use authorizations, we see products that have clinical trials. And after they complete those trials, that's when we're going to see emergency use authorizations. If we don't see emergency use authorizations following the trials, then we know that our scientific and medical community is not ready to deem these appropriate COVID treatments. So that being said, we also have nice graphics from FDA, which is a trusted source for me, which does the same thing, talks about the number of drug development programs, the trials reviewed by the FDA, and the fact that we have 11 EUAs currently and 1 approved treatment for COVID. And I pulled this right off the website, and I include the citation so people can go look for themselves, because to them, I might not be a trusted source. And I can also point out that emergency use authorizations get offered for products that then end up being ineffective, right? We know that hydroxychloroquine had an EUA removed, and that the convalescent plasma EUA was greatly refined because there wasn't showing good benefit. So that says that our scientists, this bar is not too high, that we have reached it, and that there is considerable evaluation afterwards to see whether these things are working. So at this point, I haven't amplified any misinformation about ivermectin, but I have told people that this process works in a certain way. So if they see information about how the process works, and they also see information, why isn't this magical drug approved? They can say, well, I know what the process is, and I know that we haven't gotten to the point where that drug is approved. And I have confidence in the system that we have structured to know that if it's magical, it will get approved. And if it does not get approved, then it's not something that I want to amplify use of. So it's a different way to approach misinformation, but it puts out into the space correct information and the ability for people to question what's coming at them without being directly threatening. And I think that is so important, because if someone says the sky is blue and you say, no, the sky is red, you're immediately at a conflict. But if someone says the sky is blue and then you provide them information on why at sunset it's red, we can come to an agreement that sometimes it's blue and sometimes it's red. And we have that ability to find a common space without a conflict. And that's one of the other reasons why when I approach misinformation, I try not to do it in a way that is going to be confrontational, especially online as an individual, right? We're really in a different place than speaking as a Department of Public Health or CDC, who really has that overall authority. And so that's kind of the message I wanted to talk to you about today, is just how we're making sure that we are having the most productive conversations and not amplifying things that are actually potentially going to hurt people, because I know how much strain our system is already under right now. And the less misinformation we propagate, the better we're able to actually see new science as it comes out and adapt to those changes and be able to listen to the guidance, because we're not crowding that space by trying to have to fend off what's true and not true, but we can really focus on amplifying what is true. And I am happy to talk to anyone more if they'd like to. I put my email here. It's rebeccamitchell@house.ga.gov, because thankfully I am not creative and neither is the state of Georgia on this. But I'm happy to talk to anyone anytime. And thank you so much for giving me the opportunity to chat with you today. And I'll turn it back over.
Well, Dr. Mitchell, thank you so very much for your content today. That was rich information. It is so important that we all know how to discern from fact and fiction, and especially when it comes to the vaccine information that we're getting. So I'm just truly grateful you could join us today. For those who don't know me, I am Paige Havens, and I'm the Marketing and Community Relations Consultant for Gwinnett Cares and the Gwinnett Coalition. And I'm charged with helping share information across our community about COVID care and resources. I want to talk to you today about how your voice matters and how we work together. That we've got to work together to help people work through their vaccine hesitancy. There are so many reasons why people are hesitant, and all are very real reasons to each and every person. As a community, we need to build a culture of discussion and willingness to meet people where they are, not come from a place of harsh judgment. These are unprecedented times, and frankly, there's just so much information for all of us to sort out, and we are each going to come to this decision in our own way. You know, we all know there are many conspiracy theories floating about out there, and as more research takes place and information and protocol shift, change, it's often hard to know if you're working with the latest facts. So Representative Mitchell's comments today are most important. Frankly, people are torn. We're hearing families are divided at a time when we all need to be working together and caring for each other more than ever before. The bottom line is we're all overwhelmed. We're simply exhausted by this pandemic. But there are those in our community with health conditions, that prevent them from getting the vaccine, even though they desperately, desperately want it. There are still children out there that cannot be eligible or that are not eligible yet to be vaccinated. And all of them are counting on us to do our part to make our community as safe as possible. So as you've heard today, the only way out of this pandemic is to really help our community reach herd immunity as fast as possible. And so we need your help. On this call today, we have people who are vaccinated and people who are unvaccinated. For those that are vaccinated, we need you to be loud and proud vaccine champions with us, willing to talk with everyone, to meet, talk with everyone you meet about where you stand and how to get information they need to reach a well-informed decision. For those not vaccinated, we hope that you will walk away today with some sound information that will help you strongly consider getting the vaccine. But I want to share with you what we believe to be some of the top reasons people are vaccine hesitant and offer some suggested responses for you to get the conversation started. Number one, there are those that are scared of conspiracy theories, political ploy, magnetism, chip implants. These are just simply not true, but the rumors are out there and it's hard for us to debunk them. Let's go back to what we learned from Dr. Mitchell today and help them find the sources and seek the facts. And let us be reminded that the pandemic is not about American politics. This is a global pandemic. This is not about red or blue. This is not a bipartisan or a nonpartisan, this is a nonpartisan virus attacking public health around the world. Our communities of color remember all too well past history with human experimentation. That history is real, but we are in a different age. Science, laws, and protocols have evolved well beyond that now. Technology today allows us to conduct experiments in whole new ways. Trust in the system is going to take some time, but knowledge is power, and I believe we can help everyone get there. Many young couples of childbearing age are worried about fertility and pregnancy. We've got more than a year of research studies involving hundreds of thousands of people across the globe to show there's little or no contraindications that are of concern, but those contracting COVID while pregnant are at tremendous risk. We can point to medical study after medical study to back this up. Some people are taking the naturalist approach, as we discussed, relying on their body's natural immunity to protect themselves, because especially if they think they've already had COVID. Well, it was a sound argument early on, but what we know now is the variants have learned to work around that immunity, and COVID antibodies from earlier strains will no longer protect us against this Delta variant. As the virus continues to morph again and again, our immune system simply cannot keep up without a vaccine, and the current case rates are living proof of that. Then there's the argument that if I'm still vulnerable and able to get a breakthrough case anyway, why bother? Well, I think Dr. Mrna did a great job of addressing that objection today. While those vaccinated can still contract COVID, the disease and impact is far less severe and no longer as life-threatening. Some people rely upon knowledge of past vaccines that gave you a small dose of the disease and itself to help your body build immunity. But the new mRNA technology does not work that way, and there are lots of great resources out that can educate people more about this very thing. Dr. Cadet did a great job of explaining that to us. Others feel the vaccine was developed too fast and that they just don't trust it to be safe. Now, this is where I use the example of the bridge collapse on I-85. When the governments moved out of their own way, cut the bureaucratic red tape, let the innovative private contractors come in and put the money behind it quickly, big things happened, and fast. That mRNA technology already existed. It just had to be modified to attack the coronavirus. So the brightest medical minds around the world came together, made it happen, and because we had to. So this is proof positive that the world could be a better place if we could just get world leaders to work together more often. Then there's the fear of the shot, of the side effects and the missing work. Well, this is why it helps to plan ahead and to be intentional about when you schedule your vaccine. It gives you time to mentally prepare. And if you know someone who has a fear of shots, offer to go with them, hold their hand. You can take Tylenol to lessen the side effects, and you can pick a day of the week that will minimize your time off of work. What I do know Its side effects are very short-lived, but getting COVID is a guaranteed 14 days off of work with a high potential for significant medical bills and or long-term health impacts that could mean long-term disability. And then many of our immigrants and refugee families are very concerned about having to show IDs and record their names, contact information, and health conditions in government databases. We need to assure them that they, as valued members of our community, have a right to protect themselves and their families from this virus, no matter their immigration status or citizenship. They will have access to the vaccination. They would have access to the vaccination in their own home countries, just as they do here. So COVID-19 knows no nationality, and we need everyone on board. So I could go on and give you talking points, and I'm glad to help you if you encounter someone who is throwing objections your way, but I don't want us to be scared of these conversations. They're really great answers, and we don't need to come at this from a combative tone, but really coming at it as, let's meet you where you are and let's help you get the information you need. So all too well, the COVID story today in the news is all about graphs, stats, and data. But what it's really all about is people. And so today, what we really wanted to do is share with you some stories that will leave you with some lasting impact to really help you see that this is a human condition that we are dealing with, and that we all need each other to get through this together. So I want to start with sharing my screen. We have some testimonials that we're going to share via video, and some that we're going to share in person. So I'd like to start with a pre-recorded message from Natasha Kimsey, who's a public health worker here in Gwinnett County. Let's join and listen to her story.
Hi, my name's Natasha Kimsey, and I'm a wife and mother of 2 boys, ages 10 and 12. I've worked in public health for 17 years, and as we've all experienced, the last 2 have been like none other. In public health, we plan for pandemics and role play emergencies as part of our jobs. I'm also very knowledgeable about routine and booster immunizations. I'm even a vaccine supporter of vaccines for adults and children. When I started to hear about the COVID-19 mRNA vaccines like Pfizer and Moderna, I started doing my research. I talked to anyone who knew more about these vaccines than me and listened to the experts. I had the same fears many women of childbearing age have. How will the mRNA vaccine impact my long-term health? And will this affect my ability to have children? I became infected with COVID-19 in October 2020, before the vaccines were made available. My husband tested positive first. He had upper respiratory symptoms and the telltale loss of sense of smell and taste. I got tested when I didn't have symptoms because I was obviously a close contact to him, and surprisingly, I tested positive. We were immediately worried about our children and did everything we could to keep our boys from getting COVID-19 from us. We made homemade PPE, masks, any gloves we could find, robes. We purchased a new HEPA filter and sprayed disinfectants, all this just to cook dinner at night. After about a week with no symptoms, they started to show up. I developed a cough, had sore throat, congestion, shortness of breath, and extreme fatigue. I actually ended up in urgent care one day because I couldn't talk, breathe, or swallow VitaFood. Fortunately, I was able to recover with an inhaler and some meds, but the fatigue ruined my life for the next 6 to 8 weeks. I missed 3 weeks of work, but even after that much time to recover, returning to full 10, 12-hour days proved to be too much. Despite my husband and I having COVID, our boys ended up making it through quarantine symptom-free and both tested negative. I continued my vaccine research and was relieved to read that I could have immunity for at least 90 days post-infection, according to the CDC. Some agencies speculated even longer. Either way, I believed I could continue my research through January, and eventually I decided to take the Johnson & Johnson 1-dose vaccine. After all, it was only 1 dose, and I was familiar with the vaccine technology used to create it. Soon after it was available, however, we started to hear about blood clots in women of childbearing age. And for me, the fear of getting blood clots was even worse than the fear of getting vaccinated. Now, fast forward to March 2021, my 12-year-old got infected with COVID-19. His age group was not yet approved for any vaccine, and neither was my 10-year-old. Thankfully, my oldest had a mild COVID infection, and his symptoms were similar to mine, but with no shortness of breath. The rest of my family managed to avoid getting COVID this time using our homemade PPE and sanitizing procedures we used back in October. After that, I started to have this irrational fear that I could not go through COVID again, especially the extreme fatigue. And I began to open my mind more to the mRNA vaccines. Then it happened. At work, I received a call from a single mom who had questions about giving the Pfizer vaccine to people like her who had severe allergies. This mom of two carried around an EpiPen and had not been out of her house since March of 2020. I answered her questions about the vaccines the best I could, and then she asked the question, which vaccine did you get? At that moment, I realized all of my reasons for putting vaccinations off just weren't good enough any longer. Here I was encouraging another person who is my age and in similar life situation to do it. Before I could say anything else, she said to me, "That's it, we're getting vaccinated together." 3 days later, we met at the vaccine site at Sears, introduced ourselves as new friends, and then got in line to get our vaccines together. We stayed with each other while we got poked and for a 30-minute hold and observation. We texted each other the rest of that week to make sure neither of us had severe allergic reactions. And we stayed in touch through the second dose appointments as well. I bet she'll text me soon about these booster doses. The second dose of vaccines gave me fever and chills that put me in bed for a weekend. And that made my husband hesitant to be vaccinated because he worried that missing work due to the vaccine's potential side effects was just too much. I'm sharing my story with all of you today because I was once nervous and hesitant about getting vaccinated despite working in public health and despite my research. I finally decided to get vaccinated against COVID-19 because I never want to feel so fatigued or sick that I miss out on life again. I know people who've lost their lives to COVID, and while I support everyone's right to make their own choices, including my husband, who's starting to lose the reasons to put it off game, I will never choose to miss out on life when a choice can be made to protect it. Thank you for listening.
Wow, what a powerful story. And the courageousness of Natasha to just admit where she was and how she got to a place of acceptance. So now I would like to introduce to you Mrs. Tasha Allen, who is a wife and mom of two here in Decula, who has walked a journey of great loss due to COVID. Tasha, why don't you tell us your story?
Thank you so much, Paige. First, I want to thank Dr. Rebecca Mitchell, who made the statement about we interpret things in our own lens. That was poignant and absolutely the way that I believe people interpret things. I'm the baby of 8 kids. We took this virus seriously from the very beginning. We were washing our hands. We were wearing our masks. We were sheltering in place, doing everything possible to stay clear of COVID. But COVID impacted us greatly. My oldest sister, Dr. BJ McBride, she lost her battle with COVID on August 15, 2020. Exactly a month later, her husband, Andrew McBride, he lost his battle with COVID in 2020 as well. So this was something that was very serious for our family. The oldest of the 8 was gone, her husband was gone, and what were we going to do? We were taking it seriously. So how did it impact us so greatly? When the vaccine conversation first started, we were all very hesitant, as we should be. The research was there, but we still were a part of a community that has experienced such racism when it comes to the medical industry. From the Tuskegee experiment to Henrietta Lack to all of the different stories we've heard in the past about how Black Americans have been, in fact, impacted by research. But one thing that I thought about, I said, I'm going to do the research on my own. I'm going to talk with close family members and friends that are in the medical field and in the science field, and I'm going to follow the money. And that's exactly what I did. I started watching the other groups of people, in particular, some of my white counterparts, rush to get the vaccine. I mean, they wanted to do it at any cost. It did not matter. They wanted to make sure that that vaccine was in their system. And so I said to myself, why would this race of people do everything possible to kill me, to kill my Black husband, to kill my Black son, that didn't even make any sense. So that's why I decided to get the vaccine too. I figured if it was that important to them, then it must be something that I wanted my family to have as well. And that's the reason why we chose to get the vaccine. We did our own research. We trusted our village of people who have been in science for many, many years. We trusted family members that have been nurses that are on the front line right now, still handling this virus over a year later. I can't believe it's been over a year. And I'm actually sitting in the same place I was 18 months ago, doing Zoom calls because I'm in HR, doing Zoom calls, preparing everybody for what we did not even know was about to happen with our country. But here we are still talking about this virus and still having people not sure of what to do next, what to do tomorrow. So I hope that my story, my family's story, will put a face with this virus and encourage those to do your own research, follow the money if that's what it's going to take. Do your own research, but be encouraged to do whatever you feel is necessary to protect your family. And for me, protecting my family was getting the vaccine for all of us that were qualified. We only have one unvaccinated person in my household right now, and that's my 10-year-old daughter. And she asks me on a weekly basis, when will I be able to get my vaccine? So it's important to me, and it should be important to everyone in my community. And I appreciate you even offering me the opportunity to give my small testimony. And I just hope that it will enlighten and help someone make the decision for themselves.
Tasha, thank you so much for sharing your journey with us. And we can all learn a lot from those words you share. So now I want to turn to a story that is presented by video today. Missy Price, turns out she and her husband both contracted COVID the same weekend and both needed to be hospitalized. She came home and Tony didn't. So Missy wanted to share her story. It's still very raw and very painful, but I will share her video testimony with you now.
My name is Missy Price. My husband's name was Tony Price. Tony was 50 years old when COVID took him from me and our children. COVID has taken so many things from so many people. It's taken proms, graduations, birthday parties, weddings. Some even had to be buried alone because loved ones were not able to attend funerals. For me and my kids, COVID took my husband of 21 years and the father of our 18 and 16-year-old children. Now my daughter will never have her dad to walk her down the aisle. During his hospital stay, she graduated from high school, attended her senior prom, took senior pictures without her father there, and my son, who is 16, will not have those one-on-one father-son times any longer or seek the advice of his dad. A mom can only do so much to give advice to a teenage boy. I just hope we raise them both well enough that they make the right decisions from here on out and still make their dad proud. Tony and I both tested positive for COVID back on April the 19th of 2021. It wasn't until April 25th that we both decided we were so bad we needed to get to the hospital. My parents drove from Marietta and took us both that day. I spent several hours in the ER, hooked up to IV fluids, receiving antibiotics through IVs, as well as fluids for dehydration. Unfortunately, Tony was admitted and never made it home. After 6 enduring weeks in the hospital with many ups and downs, Tony lost his battle with COVID due to ARDS, acute respiratory distress syndrome. Tony caught pneumonia with COVID and was placed on the ventilator on May the 7th, where after being placed on the ventilator, he ended up with a secondary bacterial infection of pneumonia that later required him being placed on ECMO in order to try to give his lungs time to rest and heal. This never happened. The only chance of surviving would be for him to be put on a lung transplant list, but he was never good enough shape to be put on that list. Ultimately, it was me who had to make the hard decision to take my husband off of life support. This was the hardest decision I have ever made in my life. Having to have this discussion with my teenage children was even harder. I urge all of you to get the vaccine. While getting the vaccine does not 100% guarantee that you will not get COVID, it will certainly lessen your symptoms if you do. I was one of those who thought that in the beginning, COVID was a joke. I thought people were crazy for wearing masks everywhere they went. I complained about restaurants being shut down. I rolled my eyes at coworkers behind their back who religiously use hand sanitizer every time they walk by it. While I do know that there have been some people who have experienced side effects from the vaccine, I still think these side effects far outweigh the alternative. If you do not want to get the vaccine for yourself, I urge you to get it for your loved ones. If you look at the statistics of the numbers of people hospitalized with COVID, more than half of those are not vaccinated. The number of COVID patients in ICU are mostly unvaccinated, and the number of ones who have been placed on a ventilator are all unvaccinated. My husband was in the funeral business for over 20 years, and not once did I think we'd be planning his funeral at the age of 50. Please think of others and get the vaccine to help save someone's loved one, possibly even your own.
May I hope and pray for all of us we don't have to make that decision. And finally, I'd like to introduce you to Mr. Brian Ginn. He's the Chief Campus Officer for the Philadelphia College of Osteopathic Medicine. Brian found himself within hours of being placed on a ventilator and was blessed to live to tell his story. Brian, please tell us what you have to share.
Paige, good morning, and thank you so very much for the chance to be here with you today, and to the Coalition, the GNR Health, and Gwinnett Cares for hosting this community conversation. I'm happy to be here with you today for the program, but let me rephrase that. I am blessed to be here today, vertical and alive. We've heard phenomenal presentations filled with data regarding COVID from Dr. Mrna, a true partner in the health of this community, and Dr. Cadet, my PCOM colleague here at the Philadelphia College of Osteopathic Medicine, on whom we've leaned significantly for information about how we address that issue of COVID on our campus. And then, of course, Dr. Mitchell, as a son of the South Georgia, I love the reference to purple pine trees. But the numbers that we hear today, while as important as they very much are, don't necessarily put a face to the statistics, a real face, who has individual experience with COVID. And certainly we've heard that this morning from Natasha and Tasha, and wow, from Missy, from her presentation as well. When we hit COVID back in March 2020, my institution, PCOM, an institution devoted solely to education in the health sciences, created a task force and a smaller rapid response team to address issues very quickly. I was privileged to be asked to serve on both of those groups. So I read everything about COVID, coming from the CDC to Georgia Department of Public Health, GNR Health, and listening to Dr. Mrna and the governor's office executive orders, and reading everything I could get my hands on. I was on it, man. My family and I, we were compliant. We were wearing masks. We washed hands. We were physically distanced. We tested for COVID on multiple occasions after potential possible exposures. My wife closed her small retail business for 6 months to ensure that her team members remained safe. And when we closed our campus to instruction here at PCOM, I worked from home. My wife and I cooked, and we ate, and I gained 15 pounds. And then in mid-December, we kind of relaxed, if you will, the activities associated with campus activities, and we reopened on a somewhat open basis. And so on campus on December the 16th, I arrived for a conversation with some of our team members about how we would test students coming back from the Christmas holidays for COVID. On Thursday, I go to vote in the special U.S. Senate election. And while standing in line, I began feeling unwell. Fever by the end of the day was up to 103.5. On Friday morning, I go to get tested for flu and COVID. The nurse practitioner comes in and says, "Good news, Mr. Ginn, you do not have the flu. The bad news is you have tested positive for COVID." But how can that be? I know I've read everything there is to read about COVID almost that's out there for laymen. How could that be? I just don't understand that. Well, after a weekend of high fever of 103 degrees and flu-like symptoms beyond measure and developing an insidious cough, Monday comes along and my next door neighbor, an orthopedic surgeon, calls and says, "Brian, how you doing? How you feeling?" I said, "Well, I'm making it. I'm just continuing to pop in the drugs that they gave me." And he said, "Well, do this for me. Come over to my office and let me get an x-ray of your chest." So I go over there reluctantly, and by the time I get home, this physician friend calls and says, "Listen, Brian, I'm just calling to tell you, if you don't go to the hospital right now, you will die within a week." That's pretty heady information for somebody who's just feels that they have a little bit of a bug going on. And thus began my 16-day inpatient COVID experience and my recovery that actually continues today, 9 months later. Remdesivir, convalescent blood plasma, and other therapeutic cocktails were the order of the day. Physical therapy, occupational therapy, while inpatient, respiratory therapy at all hours of the day and night. pulmonologists, cardiologists, internists galore. I think I've seen every medical specialty over the last many months that you could imagine. A medical team that was absolutely amazing. But the real fact of that medical team is that most of those medical team members, probably 85% of those medical team members who cared for me, who took care of me, but actually cared for me, did not look like me. That was an amazing experience to be cared for and cared about by so many people who did not look like me. Amazing professionals, angels in every sense of the word. Angels to include the environmental health and safety staff and the nutrition staff who came in daily to take care of my every need at that particular point in time. Absolutely amazing. The next shocker occurred when my pulmonologist came in and said, we want to give you a second round of convalescent COVID blood plasma. I argued, which is what I do. I run the administrative aspects of medical school. I argue with physicians. And so I argued with him. I haven't seen that anywhere in my research and any of the things that I've read. And he looked at me square in the eye and he says, Brian, let me just shoot straight with you. We don't know what else to do. We don't know what else to do for you. You are within 12 to 24 hours from intubation, and we don't know what else to do. That thought kept ringing in my mind. And so very quickly, I'm pretty quick, I think, for the most part. And I raised up my arms and said, well, which arm do you want to put it in? Fortunately, going through the double doors at the end of the hall, in the wing that I was on, the COVID wing, where the intubation unit was not required, as the markers started changing once they administered that second round of convalescent COVID blood plasma. And thankfully, after spending Christmas and New Year's in the hospital without family, the most difficult thing about this at all was being there somewhat alone, even though you had this amazing care team, being there without family and without knowing, because they wouldn't tell me. They didn't tell me that my wife also had COVID at home, but was thankfully not as severe of a case. So I came home on January the 5th, spent the next 5 months on oxygen, on home-based physical therapy, sitting in my leather chair, watching the events of January the 6th unfold at the Capitol. As devastating and depressing as that was part of the recovery process to vent and to be there to watch those activities taking place. And as someone who loves politics and loves good government, just to be devastated and depressed by not only my personal situation, but what I was seeing occurring in our country. I recover still. Persistent cough still exists. Lethargy and fatigue is still there and still prevalent. Stamina, I can only play 14 holes of golf and I'm done. Can't quite get a full 18 holes in. I recently had to have my gallbladder removed. Not sure if that was caused from my years of eating Southern cuisine or results from COVID. We'll tag that up to life, perhaps. But folks, I'm going to tell you, COVID fog is very real. It is very, very real. So I would leave with you today as I work through my COVID fog here this morning, the takeaways. Although I lost 30 pounds, I don't recommend COVID as a diet of choice. The absence from family when sick is devastating and is totally depressing and is consequential. And so once being back at home and being able to be with family, you feel better immediately. Medical bills totaling over $125,000 to date. A solid care team is so very important. So I urge and highly recommend each one of us, each one of our family members, to secure a primary care physician. You need a primary care physician to work through the myriad of issues should COVID come into you or your family's life. Physical distancing, wearing masks, washing hands, these work. These are aspects that work. Vaccinations are important. Although I was lit up, as my primary care physician says, by the virus and COVID blood plasma, I received my first dose exactly 90 days after discharge from the hospital, the first day I was eligible. I donated COVID blood plasma to help others. I consistently wear my pulse oximeter to check, and I'm delighted to tell you today that I'm at 98% blood oxygen level, but I carry this with me everywhere I go just to check and be sure. And then I will tell you that the things that help you get through a situation like this are family and friends, colleagues, videos that people send to you, social media, my Rotary Club, joining with my colleagues here at PCOM to send videos, And then I would simply suggest to you as the primary takeaway today, trust the science. Trust the science. My brother-in-law, a gentleman, a small business owner in South Georgia who has no scientific background. When I asked him recently, I said, well, yeah, you've already been vaccinated, so life is good, right? And he said, well, no, I haven't been vaccinated yet. I had COVID, but I haven't been vaccinated. And I said, wow, Bill, he said, well, I'm doing my research. And I said, Bill, and I can talk to him because he's a member of the family. I could not talk to someone on my campus this way, but Bill, you know, let me just put it to you this way after what I went through. Let me just suggest to you that as you do your research, go ahead and prepare your will, because you never know when COVID will hit. And I can't think of anything more direct to say to someone in my inner circle as direct as that. Plan for the future if you don't take care of opportunities that you have now. Finally, I would say to you again, as the AJC says it best this morning in the front page of the AJC, get vaccinated as its headline, saves lives. Get vaccinated, saves lives. At this point, I'm privileged to turn the podium back over, the program back over to Dr. Mrna, who has been a tremendous partner with us here at PCOM for further comments. Dr. Mrna, thank you for what you do.
Oh my goodness, what an incredible testimony, and thank you so much. I knew to pray for you and Natasha every day, and I did throughout your journey and still do. And but I didn't know at the time to pray for Tasha and Missy, but I'm a firm believer that prayer works. You have more to do in this world, Brian, and I'm certain that your testimony and that of the others shared today will really truly make a difference for people. So I know we're running short on time, but I wanted to just close with some protocols and different things, just in case, just to make sure. So if you are vaccinated, wear a mask in public. Keep washing your hands, stay home if you're sick, stay away from other people who are sick, protect your family, your kids, your community. People often ask me, what can I do to protect my grandchild who is not eligible for vaccine yet? And even if you're vaccinated, that's the best way that you can, to protect them, however. But if you're already vaccinated, do those other things as well too, so that you don't bring that in here, especially as we wait on more boosters. The other thing is, if you have symptoms, even if you're vaccinated, get a test, okay? Just even strange symptoms, like, GI symptoms or something that you don't think is related at all. If it crosses your mind, just get a test. It's available, in our communities, and there's no reason not to, and it's free. If you get COVID, even if you're vaccinated, you still have to isolate for 10 days. There's no difference. You are contagious if you have COVID, even if you're vaccinated. If you're vaccinated and you're a contact, you don't have to quarantine. And that's a great thing. And if you've had COVID recently, you don't have to quarantine for 90 days because we believe that, your chances of reinfection are very small within 90 days after receiving a positive test. But the CDC does request that even if you're vaccinated and you're a contact, you don't have to quarantine, but please get a COVID test on day 3 to 5 from the last contact, from the date of your last contact, so that you make sure that you don't pass this on without, if you don't have symptoms. Watch our website at gnrhealth.com for booster information as to when it's going to be available. There's talk about 8 months. There's talk about 6 months. I heard 5 months earlier this week. Just know when you got vaccinated. So when was the first, the day of your second vaccination? If it's an mRNA vaccine, that's the day that you were fully vaccinated. So know that date, so that if boosters become available in 8 months, you'll know when your time is there. Keep your vaccination card. Let me know, let our health department know if you need another card, if you lost yours or something, if, we can replenish those even if we didn't provide the vaccine for you. If you're not vaccinated, I think you know that all of us here today would strongly encourage you to please get vaccinated. It's not just an encouragement, it's my plea to the public. with the stress on our healthcare system, with everything out there, we just really need you to get vaccinated, and I beg you to do so. This vaccine is safe. This is the only way out of the pandemic, as we've said before. If you refuse to get vaccinated, if you don't want to for some reason or can't, please wear a mask. Please get a test if you develop any symptoms or you're thinking. Stay away from others, especially if you have symptoms. And don't assume that you'll be okay just with whatever symptoms that you have. Get a test and make sure you know what your experience is. Younger people are experiencing severe problems and are being hospitalized now more than ever. A year ago, we were worried about the 65 and older population. Now, most of those in that age category are vaccinated. So now we're worried about our younger population who are not eligible yet for vaccine. And again, remember last year at this time, we were begging for a solution. And now we have the solution to this pandemic, and we just need to increase our vaccinations, and it's not too late. We can get, there is ample vaccine available everywhere in your communities. You can text me or call me personally if you cannot find, and I'll ask Elena to put my cell phone number in the chat box, and you can call me. If you can't find a place to get vaccinated, I'll vaccinate you myself. So in any event, just do that. The other thing is, please don't go to the emergency room if you just want to test. Our hospitals are very overloaded, and a lot of people are just having mild symptoms and wanting a test. So we have ample places in our community to get testing. Don't go to the ER. Now, if you need to go to the ER for symptoms, don't delay. So please go to the emergency room if you need help. But don't go to the ER just for a test. You can come to our Gwinnett Place Mall location. We have a drive-through test Monday through a Saturday that's completely free. We don't ask for documentation. We're just going to provide it, and we'll do young children as well. The other thing is isolation is still 10 days if you're COVID positive. Quarantine is still 14 days. Quarantine can be decreased to 10 days if you're not in a congregate setting or you don't play sports, that type of thing. You can also get a test after day 5. And if it's negative, then you can go off quarantine on day 7. So in any event, get vaccinated, get your flu shots. You can get them together. There was a question in the chat about that. You can definitely get a flu shot and a COVID shot together. We can co-administer that. And take care of yourself. Get plenty of rest, which is hard to do these days, but pay attention to your body. Listen to your body, because your body will tell you if you're really, really super tired. Pay attention to that as to why. But drink half of your body weight in ounces of water is the recommended way to know how much water to drink. And that means if for example, if you weigh 150 pounds, drink 75 ounces of water every single day. And of course, get rest and watch out for your neighbor. So that's what I have for you today. And I'm going to turn this over to Paige Havens. Thank you.
Well, at this time, we're just going to open up and see if anybody has a burning question that we haven't answered today. We have covered a lot. And thanks to Elena for answering a lot of those questions as we went along, referencing various research studies or directing you to reliable resource sites. So just last call here for any final questions.
Addressing one question, Paige, that came up in the chat box. If you have visiting family from other areas of the country, if you have people visiting from out of the country, it doesn't matter if you're a US citizen, Georgia citizen, whatever, we will vaccinate anyone. So if you have people visiting from Louisiana, especially, and are not vaccinated, bring them to us. We will vaccinate every single human that comes.
We have a question here that says, what COVID test is best to take if you're testing on a weekly basis? They've been told the rapid test is not as accurate.
Right. Well, I can jump in and just say that if you're having symptoms, the rapid tests tend to be more accurate. But if you're not having symptoms and you're just checking for a weekly basis for work or for whatever reason you're doing that, the PCR is the gold standard test, and that's the best test to get. If you do test negative from a rapid test, I would suggest that you ask for, if they don't automatically offer, a confirmatory PCR test with that as well.
Great. Any other questions? I had my second Mrna vaccine in March. When will we know when we are cleared to get the booster shot? If you're not immunocompromised.
Right. So, as far as boosters go, again, we have to wait for full authorization from the FDA and the CDC to be able to give boosters. That time frame is still out there. We're not really sure when that will be, whether it'll be 6 months from fully vaccination or 8 months, or if that'll be extended. My guess is that it'll be either 8 months or before. But again, we have to wait for that. So if you just watch our website, we will be very clear to the community as to when those boosters will be available. We are planning to be available to be able to offer those to the community on September 20. However, we have to wait for authorization first to do that. But nonetheless, we're ramping up our staff and everything else to try to accommodate the demand at that time.
Dr. Mrna, what about traveling internationally? Are you okay to do a rapid test just to kind of get through, the Delta line, or do you recommend a PCR?
Well, my suggestion is to look at the CDC travel guide on their website. It's very important. Elena will put that in the chat box. It's very important because some countries are requiring vaccination before you can fly into that country. Others are requiring tests. Some are requiring, some are accepting rapid tests, some are not. And so if you just follow that, you'll have to be careful. And there's also a link in there, and I'll ask Elena to put the recommendation, the latest change from the CDC in traveling back to the United States as well, because there's some changes on that recently as well.
And that does change very often. So it's important to stay abreast of that. All right. Yes, we will be recording. We have recorded this webinar, and we will be making the recording available. Danette had asked. So I think that looks like we don't have any more burning questions. So I'm going to turn this back over to Renee Bird-Lewis to wrap us up.
Great. Well, thanks to everyone who joined today, and a special thanks to Doctors Mrna, Cadet, and Mitchell, and a really sincere and heartfelt thank you to our extra special guests, Tasha, Natasha, Missy, and Brian, who put a real face on this very terrible disease. I can only imagine the amount of courage it took to share your personal story and help us sort of step into your shoes for even a brief moment and try to understand the realities of this disease, COVID. So appreciate you very much. From a coalition perspective, we will continue our efforts to partner and support the work of public health officials and healthcare practitioners to increase the rate of vaccination. So what can you do? As Dr. Mitchell pointed out, promote only the factual information. Don't try to debunk the fiction. Just use facts and promote information that is true and accurate in your circles of influence, especially on social media. Later today, the participants in this program, the attendees, will all receive a recording link to the Healthcare Summit. So share this with others. Send this to your family members or to your friends and colleagues who are still thinking about the decision that they may make that could impact the rest of their lives. And then also the Facebook recording will also be available on the GwinnettCares.org page. So as Brian Ginn said, trust the science. We can win this race of variant versus vaccine. And final words, be well, and remember, we are better together. Thanks for joining and have a great day.